Okay, my name is Heun. I'm a consultant psychiatrist and professor of psychiatry and old age psychiatry. And today I'd like to talk about delirium, which is an acute confusional state. It's one of the very common cases in liaison psychiatry, which means this is psychiatry which connects with other medical subjects. So in a sense, it's the stereotypical response of the brain to a variety of insults. So the important part here is that the insults or the affection of the brain can be more or less from different parts. So it could be liver failure, it could be intoxication, it could be hypoxia, and the brain will respond in a very similar way. That's what's meant by stereotyped. Usually it's a response which affects the cognition. It's usually is acute onset. Sometimes could be a bit slower, but usually it would be within hours or days. And it would be cognitive impairment. It might be fluctuating. People might be better some parts of the day, especially if it's blood flow related. It can happen very often in dementia, so then things can get worse, and especially UTIs are very common to cause delirium in people with or without dementia. So usually you have cognitive impairment, you can also have behavioral abnormalities, agitation, running around, so that might be a major problem. It's very, very common in clinics, so in medical clinics, surgery, especially where there are plenty of elderly people. So the incident depends very much on the age of the people in the hospital. So it's some people say it's 10 to 20% in medical and surgical inpatients. So, as I said, it's very common in the elderly, especially after the age of 80. Happens in blind or deaf people. Can also happen in very young people when their brain is still very vulnerable. Very often it's post-operative, especially in people who have cardiac problems where the heart stops a while. Happens very often. Sorry for that. Happens very often in burn victim, in alcohol and benzodiazepine dependent people, especially when there's a withdrawal of the latter. Any serious illness, kidney disease, lung disease, can cause delirium, especially when there's a temporary deterioration. And people who have multiple disorders, that's again major risk factors. It's not without problems, because it's not only the confusion, but it's also significant risk of mortality, which is more or less related to the underlying disease. Very often the delirium is one of the cases for delayed discharges of patients. Right, so what is it precise happening with cognition? It's the impaired ability to direct, sustain, or shift attention. So people are very confused, they don't focus. There's usually a global impairment of cognition, disorientation to person, time, to environment, impairment of recent memory and abstract thinking. It's also a disturbance in the sleep-wake cycle. People might sleep during the day and might be very agitated during the night. People might be very psychomotor agitated, so running around or being very aggressive. Sometimes they're emotional labile, so they might be laughing or crying from 1 minute to the other. There's some illusions, so illusion means that people might see something in a different way. So they might see a light, and that might be a light switch, and they might see it as a microphone or an animal or something like that. Hallucinations are usually something which is not triggered by anything. So people might hear things or see things. Usually they have visual hallucinations, so they might see which is very common, small animals, spiders, might be family members. So these are hallucinations. The speech might be rambling, incoherent, and thought disordered. So the train of thoughts is sometimes difficult to detect. People might be paranoid about others. They might think that the care team is threatening or want to do something against them. Usually the onset is quite quick and it's fluctuating, as I said, within hours, minutes, or days. Usually you have some different variations of that. Some people are usually hyperactive and have an agitated delirium. So they're psychomotorically agitated, the arousal is high, their behavior is inappropriate, and they might have hallucinations. Some people are hypoactive, so they're just very lethargic, feel a bit somnolent, and are more or less psychomotorically retarded. But very often there's also a mixture of picture, and the picture can change quite quickly. Usually there might be some, if people are having mood problems or changes of mood, some might consider mood disorder as a differential diagnosis or psychotic illness, but usually in an elderly patient, it's very unlikely that a new psychotic illness starts. So if it's new in the hospital after an operation, it's most likely that it's a delirium. Dementia is very often a risk factor, and sometimes, dementia might not be even clearly recognized. But dementia has a slow onset, the course is more stable, the consciousness is usually intact, so it's not extreme sleepiness in dementia. But so this is it's, even though it's C3D, which you see very often as a psychiatrist in the dealing with elderly people, that you deal with 3D, which is dementia, delirium, and depression. So as I said, the etiology can be different. So UTIs are very common, so infections, chest infections, very common, wound infections, cellulitis, or endocarditis may be a problem. Metabolic problems, anemia, electrolyte disturbances, hepatic encephalopathy, uremia, cardiac failure, and hypothermia might be metabolic problems. Intracranial problems might be strokes, head injuries, encephalitis, tumor, or cardiovascular accidents, or sometimes increased brain pressure, intracranial pressure, hydrocephalus. Endocrine problems might be thyroid problems, parathyroid problems, hypoglycemia, diabetes, severe vitamin deficiencies. That's usually something which doesn't happen that fast. So most common in the hospital, what you see is bacterial infections or strokes. Okay, so you might have intoxications or withdrawal of medication, special alcohol, benzodiazepine, or psychotropic medication. Lithium can cause delirium. Usually people are not very sedated with lithium, but it can happen very often. Usually very common in Germany in the spring when people go on bus trips and don't drink enough, and then the lithium concentration goes high. And if it goes a bit higher than normal, you can have a delirium. Antihypertensives can make problems, diuretics, anticonvulsants, digoxin, steroids, or anti-inflammatory drugs, especially if they're taken in higher dosage. Hypoxia might be a major problem as usual. So the question is usually in the course, and as I said in the course, it's a sudden onset, fluctuating clinical course. The symptoms go slowly, but when you treat them properly, so the underlying diseases properly, which is the main intervention, then the symptoms might go away. There might be some amnesia for the delirium. People forget about that, or they don't want to remember that. and there is a mortality of the underlying disease. So let's say it that way: if the disease is whatever, hypoxia is so severe that it affects the brain, then it's a severe disease, and it can lead to mortality. So the one thing when you assess someone, it's not just looking at the cause and the causes, but also trying to find out what was the premorbid level. So you might have to have information from relatives or the GP to distinguish the delirium from dementia. Okay, so what do? Identify the underlying causes, treat the underlying disease properly. Don't do anything too fast. So if you have to get the blood levels of the sugar right, don't overdo it too fast, because then it might not help. So help the patient's condition means enough hydration, enough nutrition, sufficient pain control, and make sure that the environment is safe. Make sure that the staff doesn't threaten, or the patient doesn't feel threatened from the staff. Make sure that those who treat the patient communicate in a clear, straight manner. Make sure the patients don't fall. And make sure that there's not too much noise, not too much stimulation. So it shouldn't be too loud on the ward. Make sure the patient is immobilized, drinks enough, goes to the toilet, has his or her hearing aid, has the glasses. So all these little things which might help in orientation. If you use the reality orientation, so give clear information where you are, what you do, what is your name, where you're coming from, and what's your intention to do the things. So some people really think that they shouldn't communicate, or there's no need to communicate with a patient who's confused anyway, but it's the opposite. You should then be very clear and very straight and very open and honest and clear about your communication with the patient. Looking at medication, it's usually not too well to sedate the patient too much, because everything which sedates affects the brain, and one thing which is already affected is the brain. So usually one would, if the patient is aggressive, it's a different cup of tea, but usually you wouldn't give too much medication. Start with a single dosage of medication and increase slowly. And later, if you increase, don't do it too often. You might be as a doctor, you might be under pressure to do it very quick, but then you have to reassure the staff that things might slowly improve. One thing is usually you take low dosage, so such as haloperidol 0.5 or 1 milligram. You can think about lorazepam 0.5 to 1 milligram, and risperidone 1 to 4 milligrams, depending on the response. So you would usually start low and then see how the response is in the long term. If there is an alcohol, a benzodiazepine withdrawal, you treat with benzos, but apart from that, you would possibly go for haloperidol, an antipsychotic, especially in a patient who has delusions or paranoia, or he has hallucinations. So in these cases, haloperidol is the medication of choice. You have to review quite frequently, make sure you don't overdose, make sure that hydration is fine, patient is in a safe environment, and then you have to look to look after the patient maybe within hours or days again to see whether there's any progress. There won't be any progress very fast, because it might be fluctuate anyway. So you have to follow up until the patient is getting better. You can do a mini mental or other cognitive test, but sometimes it's extremely difficult, especially on a ward where people have been had surgical interventions. So yes, if you have cognitive impairment and you see them, they should be documented well. but too extensive cognitive tests are quite useless in this situation, and they don't help whatsoever. Don't stress the patient out and don't stress yourself out. Okay, I hope this is a decent overview. If you want to listen to more, see our other videos, and eventually we will have a textbook or whatever of videos which help yourself, your patients, or your relatives. So thanks for your interest, and if you like it, just like us and subscribe to this channel. What we intend to do with this channel is provide decent, valuable information with decent medical background. I would say I'm not an entertainer. I provide decent hands-on information, and I hope I do my best on this. Thanks for listening, and we are Global Psychiatry Archives. Thanks so much.